How's everybody doing for a Friday?
I know I have no plans today. School and work.
Well, you've made it to the end of week 8. Is this week 8? Yeah. Time flies.
Yep.
Week 7, right?
Nope. Week 8.
Oh,
Whitney. Come on, Whitney. Wake up. Okay, we'll give it a couple more minutes. We're still missing a few students.
Computer's getting on my nerves so bad.
Okay. We'll see if these last couple of students come in. Anyway, um, let's see. Cameras on, please. Jasmine, you're not in a car, are you? Jasmine? Jasmine, can you hear me? All right. Hang on, students.
Good morning.
Good morning, Donna. Sorry for the interruption. Just need to sort things out here. Okay. Welcome to week 8. All right. We got a lot to cover today. You guys made it to the end of week 8. We got a couple more weeks. This week, in my announcement this weekend, I'll send you out a roadmap for weeks 9, 10, 11, 12. However, let's just review. You guys have a lot coming up in the next couple of weeks. Okay. Okay. So next week, week 9, you have a case study, which I've opened. I know the original opening date was like September 4th. I've opened it for you that if you want to get going on that now, that's fine. Okay. Just because you have so much going on. Your HESI prep assignment is due next week. And you have Saunders. You have NCLEX. That's week 9. Okay. And the other thing you have next week, it's review week for the exam. Right? I sent you out an updated version yesterday. I'm not sure if there were any changes. There was one change. Professor Kershaw changed her HESI review to a couple of hours earlier. So go by that schedule for the exam review and for the HESI review. Okay, so 4 things next week. Case study, HESI prep assignment, Saunders, and try and get to a review for exam 3. Okay, then we jump into week 10. Vulnerable populations assignment along with your exam. And during this week are the HESI reviews. You got 3 things on week 10. You guys following along with me? Week 11 is your HESI. But remember, in week 11, you have an NCLEX, your last NCLEX. And I'll say remediation. I know it's supposed to be for week 12, but you should be working on your remediation from your HESI in week 11. If you can. As soon as you finish your HESI, get your remediation done. Okay. Everything, the remediation, let's see. Let me look at my calendar. I can tell you right now, you're going to get the dates over the weekend, but the remediation is going to be due Sunday, the 24th of September at midnight. And there's no breathing room. There's no flexibility for that. That's actually going to be the date you guys get this weekend when I put up my roadmap for all late work. So anything from any work has to be in by the 24th. And there's no exceptions. There's no that 7-day grace period doesn't exist. Okay, during that week. Okay. So my point in going through this is you got a lot going on the next couple of weeks. All right. So hopefully you've been working on these other big projects, the HESI prep and your vulnerable populations assignment. I do want to, before we even get started, really give kudos the exam scores for exam 2 for the greatly most part were awesome. So congratulations. I'm really proud of you guys. Really proud of you guys. Okay. Just fantastic. Fantastic. I appreciate your effort and your commitment. Okay, so good job. For those of you that score below a 78 and haven't reached out to me yet, please do. I really do want to go over exam 2 with you. Okay. We don't just review the concepts you missed. We review patterns. You know, if we see patterns of the way you're answering questions or what you're missing in questions, we go over that too. Okay, and try and discuss strategies for doing better on the next exam. Okay, so it's not only missing concepts. Okay, so I encourage you to reach out. The other kudos I wanted to give was to group projects. Group projects were awesome. There were a couple of projects that forgot a few things, but for the most part, they were awesome. Really, really good. So I hope, I know it's difficult to do group assignments. I get it. You're not on the same campuses. Everything's through online. I get it. I get it. Some people want to get going right away. Some people wait up till the end. I get it. But think about the nursing profession. It's all about teamwork, all about group work, right? When you're covering for people at lunch or dinner, on your floors, right? Communicating with, sitting in report or whatever you want to call it, handover, working with physicians and physical therapy, occupational therapy. So group work is important. Teamwork is one of the foundations of nursing. Okay, so that assignment wasn't put in there to make things difficult, or it really wasn't. It was to try and work within a team. I don't know if you guys are part of study groups on your campus, but you work in a team. Okay, so I know it's difficult to work with people that you don't know or you haven't worked with. So hopefully it was beneficial. But the content of your group projects was great. Okay. Let's see. What else? What else do I want to cover this morning? I think that's it. We're going to cover week 7 and 8 content from last week and this week. And then next week is actually the last week of content. Right? Week 9, that's it. So after we finish today, your HESI prep really is just about complete. Should be. Right? We've got a few. What are we covering next week? We are covering legal. Let's see. I'm not even sure that's on your HESI prep. Human abuse and violence, cultural influences in nursing. So that's the last 2 topics to cover next week. Other than that, after today, I'd be getting that HESI prep done and turned in. I really would. I hope you guys have started it. I've actually had several people turn it in. So, and remember, that's your study guide for HESI. So whatever you want to put in there, I mean, I'd like for you to think nursing process when you're filling that out. What do you want to remember about that particular topic that will help you study for HESI? Okay. Any questions? Okay. Let's do some content from week 7 and 8, and then we'll take quiz 5. And this is it for quizzes too. Okay. Candy, can you turn on your camera, please? Okay. So last week, topics we covered: infectious disease prevention and control. We think of a lot of things that can happen in the hospital setting, in the inpatient setting, right? Infectious diseases, MRSA, C. diff, those kinds of things, and communicable diseases, all right? But think about the community, okay? Lots and lots and lots of infectious diseases and communicable diseases exist. When I was in school nursing, we had a book of infectious diseases that was done by the health department. It was probably a 30, 40 page book, and each page listed a potential infectious disease or communicable disease. All the way, think about it. What kinds of things are we talking about? Conjunctivitis, hand, foot, mouth disease. What else might you see? TB, hepatitis, HIV, STDs. What else might you see in the community? COVID, flu. What else? I do need to have everybody on camera. I know when I go in
RSV.
RSV. So lots of infectious and communicable diseases within the community setting. Okay. The one thing I want you to remember, it's called the epidemiological triangle. I'm just trying to get everybody on camera. I don't want to be interrupting for this. Christina, I need your camera on, please.
She messaged the group chat saying that she just had to run to the bathroom.
Oh, okay.
I just happened to see it come through.
Okay. Thank you. Epidemiological triangle. Okay, has anybody heard of this or read about it? What is the epidemiological triangle? This is how we look at infectious and communicable diseases. It has three components: an agent, a host, and the environment. The agent is the actual bacteria or a virus or a chemical. Okay, there has to be an agent. Okay, so it could be anthrax, could be the flu, could be COVID, could be food poisoning, could be whatever the agent is. Okay, the agent needs to infect the host. Host is us, the living person, animal, whatever. That agent needs to infect the host. The host has many factors: age, comorbidities, health status, right? And then the environment is the environment in which this is happening in. So think COVID. Let's just go through the three with COVID. COVID is the agent. The host, let's say the host was either a nursing home or a healthy class or a classroom in an elementary school. Make sense? Which group is going to be more affected by COVID?
The nursing home?
The nursing home, because the elderly were much more susceptible to getting sicker and dying from COVID. Does that make sense? So the environment makes a difference. Okay. Are there, let's say we're talking about TB and we're talking about migrants. The agent is your TB, the host is migrants, the environment is crowded living conditions. Make sense?
Yeah.
So that's how we look at infectious communicable diseases by that epidemiological triangle. Of course, there's many scenarios. There's thousands and thousands of scenarios that can come out of this, right? Depending on
Are
what the
these
agent is, depending on who the host is, depending on what the environment is. That's why some people got sick from COVID, others died, others had mild symptoms. Same with the flu.
communicable diseases the same as CDC reportable disease?
Yep, we're going to get to that. Yep,
Okay.
yep. Think about the flu and think about how the flu affects different people. I don't know. Did you have the flu shot? I don't know. If you did, maybe you get through it better than people who didn't have the flu shot. So epidemiology can be confusing when we talk about in public health, but I'm just trying to simplify it for you. Okay, the triangle simply means there's an agent, there's a host, and the environment plays a factor. And think of all the different equations and scenarios that we can come up with this for every different infectious disease or communicable disease. Okay? Incubation period. What's that? Incubation, it's the time in which the infection first appears, and then when you get the signs and symptoms. So it's the time that infectious agent infects you, and then when you get symptoms. Think about chickenpox. I think about my little preschoolers. Yes, we can send a letter home saying everybody was exposed to chickenpox, FYI. But some kids may not break out with any pox for 2 weeks. So that's your incubation period. Okay. And then during those 2 weeks, using our chickenpox example, that's your communicable period. It's the time in which the agent may be transferred directly or indirectly from an infected person. So that those 2 weeks are that communicable period, right? Where those kids have been infected, maybe not if they've broken out. Okay. Think about the different kinds of where infectious diseases come from. What about communicable diseases such as food poisoning, water contamination, right? Lots and lots of potential for infectious and communicable diseases. I used to teach this in the schools, and I talk about my kids are just did you wash your hands? My kids will come out of the bathroom and they're adults with children. Did you wash your hands? Did you wash your hands? Hand hygiene is the single most important, we call it universal precautions, right? Wash your hands. Especially at home, you're working in the community, in the home setting. Proper hygiene is the most important thing to teach, especially if we're talking about bodily fluids and changing handling wounds, any kind of secretions, right? And then what Whitney said about reporting, there's a national, CDC puts out a national list of reportable diseases. Okay. The states can add on to that. Things like hepatitis. Really, what I want you to know is that that certain infectious communicable diseases are reportable. You don't need to know the list of what. For example, in the schools, we have to report pertussis on top of the CDC, the big ones, like any of the measles, pertussis, hepatitis, the ones that potentially have a larger community impact, HIV, STDs. We didn't report things like hand, foot, mouth, some of the viral ones. Okay, but just knowing that They're reportable. Who are they reportable by? Wherever well, schools, doctors' offices, hospitals. Let's say you have and you're reporting to the local health department. Let's say you have a bunch of kids who come to the ER and they have all GI symptoms and they've all eaten at the same place. That's reportable, right? Because we want then the local health department to reach out to other area hospitals to see if anybody else is coming in. That's how you start to talk about outbreaks. Okay? So surveillance and outbreaks, right? You do follow the nursing process when we're doing observation or surveillance. You collect the data, analyze it, interpret it, communicate to whoever needs to be communicated to monitor it. So going back to the kids showing up at the ER, what do you tell these kids? Do they go back to class? Do they take over-the-counter medications? And I'm just talking about dissemination of health data. Once you're looking at an outbreak, you have to be able to communicate effectively to the people that need to know information, right? What if there's a natural disaster and the water's been contaminated? How do you communicate to the community when it's safe to drink the water again, or how to prepare safe water, right? So the difference between observation and surveillance, simple. Observation is simply to assess the public health status. I'm in here in the notes, identify trends of disease patterns, figure out what resources you need. It's observing the whole system, identifying the health status, what are their disease patterns, setting priorities for using resources, and then develop programs for rapid response. That's the observation part of it. Surveillance is pretty simple. It's to reduce morbidity and mortality, right? You're trying to prevent you're trying to control the spread. Okay? You're not focused on eliminating it. You're trying to control the spread. And that's what was happening during COVID. Okay? There are different kinds of patterns of occurrences in outbreaks, and I highlighted these in particular in yellow right here. I just need you to know what they are and be able to give an example of one. It's pretty simple. Point source. Okay, that's when everybody's been exposed at the same time. So that would be like releasing a poisonous gas on a train. Everybody gets sick at the same time. There's a point source, or you can point to a source. Intermittent, okay, means just intermittent, that you're exposed over a period of time with people getting sick at different times. Food poisoning is a good example of that. Let's say a Mexican restaurant has a batch of avocados and they're bad, but they use them over a couple of days. Okay, and people get sick at different times. It's intermittent. A mixed outbreak is when you're exposed and then the person spreads it from one person to another, like the flu. Okay? I know these are fancy words. I just want you to know the gist of each one. And then the propagated, there's no common source. Okay, it's propagated. They gradually spread from person to person. An example of this would be TB. Okay? You with me?
Mm-hmm.
Okay. Vaccines. Vaccines are the single most effective method in preventing and controlling communicable diseases. Okay? we worked a lot. I worked a lot with vaccines in the schools. Okay. What do you do if a parent doesn't want to, or a guardian doesn't want to vaccinate their child? What do you do? Do you berate them and judge them and
Educate them.
educate? Educate. That's the answer. Educate. Parents have every right to refuse vaccines. In our well, it's in our state, they had 3 ways to refuse. A personal exemption, which means philosophically, I'm not going there. I don't want to vaccinate my kids. Then you have religious exemptions. There's certain religions that prevent or discourage immunizations, right? And then there's a medical exemption. Maybe the person has a comorbidity that the doctor feels that the risk would outweigh the benefits. In Colorado, parents, if they're going to refuse the vaccines, they actually have to get on the website, the Colorado Department of Health website, and watch a video. And it's an education video of, yes, we respect your decision. However, here are some things you need to think about. And so the parents have to actually watch a video and sign a consent that they watch the video. And then their personal or religious or medical exemption gets attached to that. Yes, I watched the video sheet. And then they provide that to the schools. So it is their choice. It is their choice. There are certain groups that might be more at risk for not being immunized. Okay. Infants and toddlers is the group most vulnerable to these potentially severe diseases. Yet they are a high-risk group for not receiving the scheduled immunizations. Okay, research shows that inner city kids from minority and ethnic groups are particularly at risk for incomplete immunizations. Think about all the families coming over our borders, coming into the schools with no immunization records. So there's a lot to think about with immunizations. A lot to think about. Okay. Then the HPV vaccine I want to mention in particular protects against most prevalent infections, such as genital warts, precancerous cervical lesions. But it's a misconception that it does not, it's a misconception that it prevents all kind of HPV infections. It doesn't. Okay. HIV, let's talk about STDs. Major public health challenge in the United States, right? There's 2 kinds of STDs, is bacterial and viral. All right, bacterial can be treated. Gonorrhea, syphilis, chlamydia. Okay. Most of these are cured by antibiotics. Okay. What about viral? Viral STDs can't be cured. You end up with a lifetime of symptom management and infection control. Okay. The one particular STD I want to mention is syphilis, because in the community, we're working with pregnant women. Syphilis can be transferred to the fetus, transplacentally. Everybody knows what that means, right? Mom to fetus. Okay, if syphilis is not treated, it can lead to very poor outcomes for the baby. Okay, that's why those screenings are done at the beginning. STD screenings are done at the beginning of pregnancy, or at least a history is done. Okay. So you can have a look at these STDs I've outlined for you, whether they're bacterial, viral, how they're treated. Have a look at those. Hepatitis. And for some of you that did the group projects on hepatitis or HIV, you're already way ahead because you know all this information, which is great. Hepatitis. What's the difference? I want you to know the difference between hepatitis A, B, and C. And it's all listed up. Can somebody that did the group project on hepatitis tell us what A, B, and C is?
A is, well, I'm not in the group.
That's okay.
Well, I know A comes from fecal when you don't wash your hands and you touch food.
Yep. Okay. What about B? Who wants to talk about B? Oh, come on, guys. Who did hepatitis?
B has to do with like sex, having contracting it through anal sex or bodily fluids.
Correct. Thank you. Okay. What about C?
Isn't C bloodborne as well?
Mm-hmm. Mm-hmm. IV drug users.
IV drugs user.
Mm-hmm. Mm-hmm. 85% of people that contract hepatitis C develop chronic or lifelong, it's a chronic and lifelong infection for them. Can lead to liver damage, cirrhosis. Okay. Then HIV. You need to know about HIV. Okay, bloodborne infection spread through sexual contact, sharing of needles. Okay, the one thing that's important about HIV is testing, right? When you test, okay, the test cannot identify or may not identify infections that may have been acquired in the previous 3 months before the test.
Oh.
So there may be a false negative or false positive. Okay. So in order to detect the HIV antibody, that could take up to 12 weeks. So what we need to do is encourage those clients to be retested in 3 months. Right?
Yep.
What about the HIV infected clients that are entering into the correctional system? Crowded living conditions. Okay. They too need to be carefully screened and have to be considered non-infectious before they go into that facility. Right? Why? A person with HIV is much more susceptible because of their reduced immune system, much more susceptible to infections. And in particular, in the correctional system, TB. Okay. What do we know about TB? Spread through airborne droplets. Right? 95% of people, it becomes latent. I mean, everybody's had a TB test, right? Every time you start a new job, you have to have a TB test, right? Okay. What if you're working with a client in the community, in their home that has active TB? One of the things about TB is when they're put on medication and they're in the home setting, that is a mandatory visit by a home health nurse. That is mandated by the health department. You have to be visiting to make sure they're taking their medication, whether they want you there or not. I mean, it's the equivalent of the reporting of child abuse. You have to go investigate. Well, with TB, you must go to the home or the environment where the positive person is to ensure they're taking their medication. It's a mandated visit. What about people that don't want anybody to know they have TB or they're in denial they have it? It can be problematic. What precautions do you need to take in the hospital, in the home? Precautions do family members need to take? So need to think about those. Certainly an N95 mask that has a filter respirator needs to be worn by anybody entering the home, the room in the hospital, the room in the long-term rehab. Okay. Let's talk about bioterrorism and disaster management. Okay, nurses in the community that work in public health, the expectation is that we can participate in any part of a disaster. Okay, whether it's the education the education to prepare, the actual impact stage, the aftermath, the recovery phase. We're expected in the community setting to be able to participate in any of those, whether it's triaging on site, whether it's working in a shelter after to help people get their medications or whatever, get their whatever resources they need. There's two kinds of disasters. There's man-made and human. Okay. Natural disasters are obviously events that occur naturally. Earthquakes, communicable disease epidemics, droughts, hurricanes. Man-made is what we create. Pollution, warfare, fires, water contamination, food poisoning. Okay? So one of the most important things about disaster management is how do we prepare? How do we alert? How do we communicate potential disasters within the population? Just the most recent example is the last couple of days with that Florida hurricane. Okay? Think of we all work in environments that have drills, right? They have disaster preparedness drills, right? Or evacuation drills or fire drills. In the schools, we had fire drills, evacuation drills. They all serve a purpose. It's preparedness. Is your community prepared for a disaster? And what is the plan? What is everybody's job? Okay, so when we do these drills, in whatever setting you're in, it's all about preparedness, communication, and response. How well do we do? I mean, you look at different disasters over the last couple of years, and some have been handled without a hitch. Others have been handled in a different way, or you can tell that they weren't fully prepared. Okay. So one of the things that you might be working with families in the community is how to put together a kit for disaster. What do they need? Well, I have this highlighted purple here. There's a couple of things. Let's assume you're working as a community nurse and you are working in the preparedness stage. What do you tell families? Well, we need enough food for 3 days. We review the kit every 6 months for anything expired, right? All members of the family need to know where the kit is located, and all members need to know where the shutoff is, utility shutoff. Okay? Bioterrorism. Let's say there's a bioterrorism attack. Anthrax, with smallpox, with sarin. Okay, those are the most common that we talk about in this class. Okay, this is information right here you can put on your HESI prep. Okay, The one thing I want to mention, and I'm quickly going through this, you are responsible for all the information on these pages, but I'm highlighting the important points. What's the difference between smallpox, and I'm sure you've covered a lot of this in med-surg. What's the difference between smallpox and chickenpox? How do you distinguish the difference?
Chickenpox starts with a rash. Smallpox starts with like flu-like symptoms.
Okay, that's part of it. What about location? Location of lesions. The difference is lesions of smallpox are found
In
on
the hands.
Yeah, the hands and the feet. Palms of the hands, soles of the feet. Okay, they do not appear there with chickenpox. That's the big difference. Okay. We talked about foodborne illnesses. You have waterborne illnesses, water contamination, post-disaster. You hear a lot about cholera and giardia, right? Those are waterborne illnesses that come from contaminated water. Then we also have vector-borne illnesses, right? Lyme disease, ticks, Zika, Rocky Mountain spotted fever, malaria. Okay. So lots of information. Let's shift gears here and talk about this week. Home care. Okay. You're a community nurse working in home care. The biggest point about home care is you're working in the home environment, right? You're working in the client's home. Okay. One of the things we need to think about is, since we're in the client's home, we are their guest, right? So your assessment is may take longer than, say, in the hospital setting. And this is down here. Whoops. The nursing assessment may take longer for the home care nurse, because when working in a home, you're the guest. To be effective, you need to establish that trust, right? Trust with the client, trust with the family, right? So that's important in home care. Okay. The home health nurse is pretty autonomous, meaning she's out there by herself doing her home visits. She's not working on a floor in a hospital where she has lots of resources with her, right? So the home nurse is pretty autonomous, but has to have coverage to be able to report back any issues, whether it be their agency, their boss, the doctor, whomever. Okay, so you got to remember that. Okay, one of the systems that came out of home care way back was called the Omaha system. Okay, and I have this down here. Typically, home health is a combination of a lot of services. Somebody may be coming in to do wound care. Somebody may be coming in to do IV antibiotics. Somebody may be coming in to help prepare meals, figure out medication. Maybe somebody's getting physical therapy, whatever. Typically, a home health client has lots of things going on. So this Omaha system was developed way back when by the Visiting Nurses Association, and it had to do with documentation. Okay, documentation needs, right? And that was the point in which everything was put into a central location, so all the other services working with this client could see. Does that make sense? Everybody knew what everybody was doing. That's the whole purpose of the Omaha system. The other thing in home care that's important is Medicare regulations. Lots of home care is dictated by Medicare regulations. Okay. So many of the services that can be provided to the client can be provided either in-home or on a consulting basis or maybe telehealth. Okay, all that has to do with Medicare or Medicare regulations, Medicare reimbursement. I just had a family member that was discharged from the hospital 3 weeks ago that had been in there for 5 months. And most of the case management, caseworker's job, because the family member's on Medicare, most of all the planning she was doing had to do with Medicare. Well, Medicare approved this. Here's what Medicare says we have to do. Okay. The other thing with Medicare they're very big on is the sharing of information. Okay. It's much more effective to be able to share information with all the services being provided, kind of like the Omaha system. Okay. Especially when you're transferring clients from, say, the hospital to home or the hospital to the rehab. Okay. Community resources. As a community nurse, you have to be a wealth of knowledge. Okay. As a school nurse for 22 years, there wasn't a resource I didn't have. If I didn't have it, I would find it. Okay. Because most of your clients in the community are going to need some kind of resources. Okay. Especially think about the clients in the community, chronic complex diseases. Maybe they need or clients living in poverty. There's lots of resources in every community, and community nurses, public health nurses need to be aware of those resources. Okay. Nonprofit organizations, volunteer organizations, let's say Meals on Wheels, Red Cross, food banks, clothing banks, transportation services, maybe domestic violence shelters, churches, lots of different resources in the community. And then health resources as well. Maybe families don't have insurance. What doctors in the community take patients without insurance? Who takes Medicare? Who takes Medicaid? So community resources is an important part of our job. Okay. What do you do if you are working in a community that has a large population of non-English speaking immigrants? Can be very challenging. Okay. You've got to be able to network, get with your team member, get with your community leaders, find out who in the community can assist you with this population. How do you communicate about healthcare, where to go? Okay, so with our very diverse culture now, we have lots of communities that have non-English speaking people. Okay. If you don't speak the language, maybe you need an interpreter. Maybe you need a translator. I know in the school, I mean, I don't speak another language. In the schools, if I was working with a Hispanic or whatever, Hispanic, Vietnamese, Russian, Hungarian family, I would make sure I had a translator at our meeting. You have to try and communicate with them in their primary language. That's the only way they're going to understand. Case management. Case management is a part of the bigger umbrella called care management. All right. We all hear about our managed care systems, the big insurance companies, the Cignas, the Blue Cross Blue Shield. Those are our that falls under the care management. Okay, the kind of the big corporations, big insurance corporations. Case management is within these corporations, all right, and within the hospital. Case management, if you're asked to be a case manager, you are coordinating care. Okay, a lot of these insurance companies have lots of case managers because it's financially effective to have somebody managing a complex client, managing all the resources they need. Think about a very complex client with lots of chronic diseases being discharged from the hospital to the home. Think of all the services they might need. Think of a person who has lots of mental illnesses and also has substance issues. Think about the resources they're going to need. Okay, case managers usually work with the high risk, high need population. Not everybody needs a case manager. I mean, if you've been in the hospital with a bypass, let's say you have a cardiac surgery, you're all set up for cardiac rehab. Somebody lives at home with you. Somebody can help you. You don't need a case manager, right? But what if that same patient lives alone, doesn't have any transportation to get to cardiac rehab? That client might need a case manager to help organize services for them, right? It's really labor intensive. Okay, it's very time consuming. This case manager that worked with our family member, oh my gosh, hours and hours and hours trying to coordinate resources and services. And it was unbelievable how much time this case manager spent on this family member's case. Okay. There's during case management, and this really kind of goes with nursing in general, but it's particularly introduced here with case management. It requires varied types of communication. Okay, there's 4 types of basic communication that's listed here for a case manager. Just please know the difference between these 4. Collaboration, assertiveness, cooperation, and compromising. It's right here. Okay, collaborating. We're attempting to collaborate, work with others to try and come up with a solution that satisfies both parties. So you're collaborating. Assertiveness is presenting your own side. Cooperation is the ability to understand and meet the needs of others. Okay? And then compromising, you try and find a mutually acceptable solution that is partially satisfies both parties. So there's a difference. Okay? So trust in public health, trust in community health needs to be developed before a crisis occurs. Okay? So let's go back to that community that has, let's say there's a lot of migrants and we know there's a large population of undocumented residents, right? Let's say there's some kind of an outbreak or something and they need to be immunized. We need to have some kind of a plan in place for them. Who's going to communicate with them? Who's going to make sure that they get the services they need without fear of immigration issues? I mean, that's what communities are dealing with now, right? You're non-English speaking, you're immigrants, maybe you're non-documented population. We had a lot of undocumented families come into the schools. They can't be questioned about their immigration status. These kids are registered and start school the next day. So we have to be mindful of that. Okay. And then the last part is care of chronic complex illnesses. Post-op. What kinds of things are we looking at for post-op? How do we prevent complications? When you're delegating in the post-op, can you delegate? Can an LPN delegate an unstable patient? No. Right? When we're delegating, this is in the post-op area, post-op part. When we're delegating, what do we need to do? We need to be able to tell who we're delegating to. What's to be done? How's it supposed to be done? What needs to be documented? Because remember, whatever you delegate, you're responsible for. There were many times in the school setting I had to pull my delegation for my aides that worked in the clinics. Whether it was mistakes caring for a kid with diabetes or just not keeping up with paperwork, whatever. Several occasions I had to pull my delegation. Be careful. Let's say you're on a unit that you have somebody floating to you. Floating came up in the last, did floating come up in the last exam?
Yes.
Floating. Let's
Yes.
say you get floated to a unit you've never worked on before,
Mm-hmm.
right? Yeah, you got to go. However, the best way to communicate is, hey, here's what I can safely do, but here's what I can't do. And that's under the delegation clause as well. If you're the manager on that floor and you're asking somebody that's floated to you to do things that they're not competent in doing, that's a real big risk. Some of the diseases I would like for you to take a look at, the complex chronic diseases, cirrhosis. I give you, I think, 5 of them and what it is and what the interventions are. You're going to get asked about these on exam 3. All right. By the way, I'm working on the blueprint concept guide. I'm working on it. I hope to get it to you guys this weekend. So you'll have it for a couple of weeks. So take a look at cirrhosis. All this has been introduced to you in MedSurg. Okay. COPD, diabetes, peripheral artery disease, chronic venous insufficiency, and hypertension. Okay, you need to know about these, what they are and what the interventions are in the community setting. The interventions may be similar to the hospital setting, but they also might be different in the community. Okay. So, questions. That's a lot to cover. Your blueprint concept guide that I get to you will be an abbreviated version of all of these notes. Okay? I'm going to really try and target in what you I mean, the notes are a big overview of the topic, of the concept. Okay, so that gives you the deeper understanding of what we're talking about. With this concept guide, I'll hone it in on what exactly are the most important points you need to know for each concept going into the exam. Okay? Questions about anything we covered today? I mean, it's just expanding your knowledge base of what community nursing is. You're not expected, this class is an overview of how we provide care in the community setting and who we provide it to. So I hope you're realizing as we go through week by week, just how much there is in this scope of public health and community nursing. There's a lot to consider. All right, let's do exam. Let's do quiz 5. It is 10:02. So let's go to, how about if we go to 10:20? That gives you about 17 minutes to take the exam, or 18 minutes. Okay, to take the quiz. Submit it when you're done. I don't need to know when you're done. Okay. Stay on after you finish. If you need to go to the bathroom, whatever, go do that. But everybody mute themselves. Take your time doing this. It's your last quiz. And then you got to stay on camera for the quiz. Okay. And then we'll see you in 20 minutes, 15 minutes. 17. All right. Okay, we all done? Okay. How'd you do?
Good.
Okay. Let's review the questions or the answers. Let me share my screen here. Okay. So the school nurse notes several children developing a pustular rash on their face and extremities following several days of fever and malaise. What steps are we going to take? What did we just cover? What is that?
Notify smallpox.
Smallpox.
Yeah.
Outbreak.
Yeah. Those are some symptoms of potential smallpox. Nurse caring for an immigrant who is pregnant with their first child, there's no vaccinations on record. Which vaccinations should be prioritized?
Rubella.
Why is rubella the right answer?
Rubella is very important in pregnancy because the disease is dangerous. And especially if she doesn't have any vaccination record, I think that would be a priority first.
Yeah, that's exactly right. Health department is caring for a 16-year-old female with a new diagnosis of gonorrhea. Which education do we need to provide?
Call to report any pelvic or abdominal pain or fever.
Why? Why?
That's like infection, like something else is going on.
Right.
Exactly. Yes, yes. And really the rest of the other answers are actually incorrect information. Right? You wouldn't want to be teaching any of those other answers. Okay. Occupational health nurse is caring for a client who just had a needle stick injury at work. Which education would the nurse provide regarding HIV testing?
Return for another HIV test in 3 months to determine.
3 months. 3 months. Yep. Yep. And again, the other three answers are incorrect information to provide.
Mhm.
The nurse is developing a primary prevention program for TB. Which intervention is appropriate?
Reduce crowded living conditions in our community.
You're trying to prevent, right? You're trying to, that's one of the biggest factors in the spread of TB, right?
Right.
Okay. Home health nurse is visiting a client recovering for a hip replacement from 8 days ago. The client's complaining of calf pain in the left leg. Which intervention is a priority? A key word, priority.
Assess the left calf for edema or erythema.
Right. What could that be a potential sign of?
It can be blood clots.
Blood clots. Blood clots. Yep. Home health nurse is caring for a client with chronic peripheral artery disease in both legs. Which should be included in the education?
Stop smoking.
Stop smoking. Stop smoking. Which dietary modifications should be used in a client with COPD?
Rest before starting a meal.
Right. Right. We don't, the other answers are incorrect information. Okay, the home health nurse is caring for a client with cirrhosis who lives alone. Which intervention is a priority?
Evaluate gait and environment for fall risks.
Right, right, right. Now the other answers could be correct, right? But what is the question asking?
Priority.
What's the first thing we need to do?
Safety.
Safety.
First.
Safety. Exactly. And then lastly, which food should be avoided by the client with poorly controlled hypertension?
And
Cancer.
soup.
Yeah, lots of sodium,
Mhm.
right?
Right.
So you did okay on this? Good.
Mhm.
All right. All right. So, you've got your marching orders from me, right? Busy couple of weeks coming up. Get some work done. Maybe, we've technically got 15 minutes left in the class, even though we didn't take a break. Maybe take the 15 minutes to jump back to your HESI prep and put all this new information in there from today. Okay, and then get that turned in. All right. Does anybody have any questions? We're in the home stretch. We are in the home stretch.
The HESI prep, do we need to add like the references on there too?
No. Mm-mm.
Okay.
Remember, this is your own study guide. No references. Nope. Okay. Then try and prioritize coming to a review next week. Try and prioritize getting to a HESI review. I know week 10 is hugely busy for you guys. But those are the week 10 because you go right from exam 3 to HESI. But remember, there are HESI reviews that week. Okay.
Okay.
I hope you guys all have a good weekend. Reach out if you need anything. Okay.
Thank you, you too.
Yeah, thank you. And we'll see you next week.
Okay, thank you.
All right.
Thank you.
Bye, everybody.
Bye.